Golden sun upon the sea,
golden sun is over me.
Ukulele melody,
drifting on a gentle breeze.
Let the worries fall away
on this slow.
Hey guys, Uncle Sully here with Richie. Richie, got anything to say? No, he's quiet today. I got another food video for you. This one's actually not about food, it's about vitamins. It's vitamin B12. Very important to us old guys, you know. I've actually prescribed to it because I had cancer surgery, and what they did is they took out a piece of my intestine. I know, too much information, right? And it made a fake bladder for me. It's called a neo bladder. Not like the guy from The Matrix. A neo bladder. So I don't actually have to have like a bag. Oh God, this is too much information, isn't it? When you get older, you know, it could happen. It could happen to anybody. You don't have to get older. You could have a really nasty car accident, or you can have bladder issues when you're younger that these people have. It's not uncommon. You'd be actually very surprised. So I digress into creepy land. This is about vitamin B12. I have not seen it, so let's dig in and see what they got to say about vitamin B12.
Welcome to this explainer. You know, as a geriatric clinician, there's a diagnostic trap that literally keeps me up at night. It's a trap that's causing irreversible cognitive decline in up to 40% of our older patients. So today, we're going to look really closely at how we evaluate, test, and treat what often masquerades as a degenerative disease, like dementia, but is actually something far more treatable. So, is it dementia or a missed vitamin deficiency? Let's get right into this critical clinical question, because a massive percentage...
Okay, well, this got me sideways here. This threw me off. I didn't know it had anything to do with cognitive decline. I take it for another reason, I guess, for digestion. I don't know. Now that I'm thinking about it, it's like they took a piece of my intestine out. I'm assuming that was part of my intestines that absorb vitamin B12 from food. That's why I'm thinking why I take it, but this is going in a different direction. Let's take that side road and see where we find out where we're going.
Showing up with cognitive and mood symptoms are actually dealing with a completely preventable, misdiagnosed nutritional deficiency. We're talking about vitamin B12 or cobalamin deficiency. The literature shows up to 40% of older adults suffer from this, often because of gastrointestinal malabsorption issues like atrophic gastritis, which is essentially just the wear and tear and thinning of the stomach lining over decades. But because of how our standard medical system tests for this deficiency, it just slips right under our radar. Here's our clinical rounds roadmap for today's explainer. We'll quickly hit the hidden warning signs, why standard tests fail, the 350 threshold, the role of MMA.
I'm assuming one of the hidden warning signs was you keep forgetting to take your vitamin B12.
Finally, treatment and reversal.
Part 1, the hidden warning signs.
Sorry, that seemed to be skipping
the
some stuff.
neuropsychiatric symptoms.
What we're looking for in the clinic really isn't just anemia. Honestly, devastating neuropsychiatric symptoms like psychosis, severe depression, and memory loss usually show up way before any abnormal blood counts. For decades, the hallmark of B12 deficiency was thought to be hematologic, macrocytic anemia. But the evidence actually shows that neurologic signs and symptoms develop well before those hematologic findings. We see paresthesias, those pins and needles sensations, a loss of proprioception, meaning patients quite literally lose track of where their feet are in space, and profound cognitive changes first. I've personally seen patients referred for early onset Alzheimer's whose primary issue wasn't plaque buildup, but starved neurons. The blood counts, like the large ineffective red blood cells you see in macrocytic anemia, actually show up much later. Here is the crucial takeaway. If we just brush off these mood or cognitive changes as simply getting older, we are risking allowing our patients to develop permanent periventricular white matter lesions. To put it simply, this is irreversible scarring on the brain's communication highways. Cobalamin is the...
Wow, this is all new stuff for me. Have you guys heard about this? Vitamin B12 new deficiencies cause all these cognitive issues? And what did she say? tingly parts. I get that. I think we all get that when you sit a certain way, and like your fingers fall asleep or your leg falls asleep. I hope that's not a sign. Maybe I'm in the first signs of this. I'm going to take my B12 right after I make this video.
Central nervous system needs to maintain its myelin sheath, the insulation around our nerves. When it's missing, we see derangements in neurotransmitter production and actual physical myelin damage in the brain and spinal cord. Moving on to part 2, why standard tests fail, and the diagnostic trap we so often fall into. There is a really dangerous contrast between the standard laboratory normal range and the actual clinical reality. We can miss up to 50% of true tissue level deficiencies just by blindly trusting that 180 to 900 picograms per milliliter range. Relying solely on this population statistic average is a massive trap. Patients can have active neurodegenerative disease processes occurring right smack in the middle of this supposedly normal range. A standard B12 draw? It's often measuring fool's gold. It detects inactive forms of cobalamin, meaning the serum can look perfectly fine on a lab report while the patient's brain and nervous system are effectively starving. As a deficiency develops, the body brilliantly but deceptively maintains serum values at the expense of tissue cobalamin. Standard radioimmunoassays detect these inactive forms, giving us a false sense of security, while permanent structural damage happens quietly at the cellular level. Section 3, the 350 threshold, and redefining what normal really means. 350. If an older patient's serum cobalamin is below 350 picograms per milliliter, consider them at risk, period. You have to look deeper immediately, regardless of what that lab's normal cutoff says. In practice...
Now, I'm assuming most people don't get these tests, but they probably should. I don't know, maybe when you get to a certain age, the doctor automatically does it. I don't remember that. I didn't have cancer surgery until I was 61. And at that point, because of, like I told you before, a piece of my intestine was taken out. Then she started measuring my B12 levels. I don't know. Is that a normal thing? I guess, given the idea of what they're talking about here, boy, it seems important to go ahead and test for that, huh? Anyway, let's move on.
Red line. An adequate supply is generally suggested by levels well above 350. Anything below this, particularly in an older adult presenting with a sudden change in mood, gait, or memory, requires an immediate, deeper clinical look. We simply cannot afford to wait for levels to drop into the hundreds. Part 4. The role of MMA as the true indicator. So we measure methylmalonic acid, or MMA. This metabolic
They're not talking about mixed martial arts, I'm assuming.
Early in the disease process, right when the mitochondria lack the active B12 needed for lipid and protein metabolism. You see, inside the mitochondria, active B12 is the spark plug needed to convert methylmalonyl coenzyme A. When B12 is missing, that engine seizes up, and MMA builds up rapidly in the bloodstream. Think of elevated MMA like black smoke pouring out of a car's exhaust. It's the definitive chemical proof that the cellular engine is starving for fuel. High MMA and high homocysteine levels actually precede clinical symptoms and low serum B12. These are your true red flags for tissue starvation, appearing way before the patient's blood work drops into the traditional danger zone. Now, while homocysteine can also be elevated due to a simple folate deficiency, MMA is highly specific to a metabolic vitamin B12 deficiency. Homocysteine is a general warning light on the dashboard. MMA is the specific diagnostic code telling us exactly what is failing inside the patient's cells. Section 5. Our clinical testing workflow, and how to use the algorithm. When we apply this decision tree for our at-risk populations, we can finally bypass those traditional diagnostic pitfalls. We start by identifying who's at risk: the elderly, folks with autoimmune GI pathology.
This notebook LM seems to give me graphs and charts and information that's so small you can't read it. And I apologize for that. This is about my 4th video that seems to have information that's in such small text there's no way you could read it. Maybe you guys can zoom in and read that. I can't, even though I have a 25-inch monitor or something like that. So anyway, sorry about that, guys.
Or patients on long-term medication like PPIs for acid reflux or metformin for diabetes, both of which actively block intestinal B12 absorption. It's a straightforward 3-step process. Step 1, screen yearly for B12 levels. Step 2, if it comes back under 350, test the MMA. And step 3, if that MMA is high, after you've ruled out renal issues because failing kidneys can falsely elevate MMA levels on their own, you've got your diagnosis and you must begin supplementation. If MMA testing isn't available or the cost is prohibitive, the clinical consensus is to look at the patient sitting in front of you. If levels are below 350 and they have symptoms, the benefits of supplementing far outweigh the risks.
Finally, Section 6, Treatment and Reversal, the path forward.
Surprisingly, high-dose oral supplementation, 1,000 micrograms daily, is usually just as effective as those painful intramuscular injections. And let's be honest, those IM shots are quite literally a pain in the butt for our patients. This oral route works because massive doses can passively diffuse through the intestinal mucosa, even in patients with severe malabsorption issues. Even if a patient lacks intrinsic factor, about 1 to 5% of a massive oral dose is absorbed via passive diffusion. This is an absolute game changer for patient compliance. We really only need to subject our patients to weekly or monthly injections if oral compliance fails or is proven ineffective. By catching this early, we can reverse those metabolic abnormalities, boost depression treatment responses, and stop structural brain damage dead in its tracks. The target here is maintaining serum levels between 400 and 500 picograms per milliliter. The goal isn't just to get them barely above the 350 deficiency line. We want a buffer, right? We want to safely maintain them in a robust, mid-normal range to protect their neurologic function long-term. We've even seen that adequate B12 levels in this range correlate with a much better response to standard antidepressant therapies. So, will you rethink the normal range on your next patient's lab report? The next time an older patient presents with sudden cognitive decline, severe depression, or confusing neurologic symptoms, ask yourself, are you trusting a mathematically flawed reference range on a piece of paper, or are you looking for the real metabolic truth inside their cells? Catching this early is literally the difference between a reversible vitamin issue and permanent life-altering dementia. Rethink that 350 threshold, check the MMA, and don't hesitate to treat. Thanks so much for joining me for this explainer.
Well, that had interesting information. I would assume you would try, well, take your multivitamin, I guess. I'm not really sure how much vitamin B12 is in a regular multivitamin. But if you're getting to the point where this concerns you watching this video, it definitely concerned me. I'm taking it already, and my vitamin B12s, they test every 6 months or so. I have blood tests because of my cancer diagnosis. I had blood tests every 6 months or so. And they test my vitamin B12 levels. But there may be something you want to think about, or maybe just make sure that you take a multivitamin that's got a good amount of vitamin B12. I can't tell you how much is in a normal multivitamin. So there you are. There's some stuff to look up. Take a look and make sure that you're getting enough, and whether this concerns you, whether you should, this is something that you should do something about. So anyway, it was pretty good information. Uncle Sully signing off. I got more videos. They're just going to keep on coming whether you like it or not. So anyway, thanks everybody for watching. Aloha from Maui.
Golden sun upon the sea.
Golden sun is over me.